Hello, welcome everyone. That clock always gets me with the little ticking time bomb. I don't know if you guys can hear it on your end, but welcome to today's webinar. My name is Hiva Kaladrabidz. I am a content creator here at Archer Review. I have put together a webinar for you guys today on pediatrics. This is for the primary care clinician, the nurse practitioner. This is going to be a really nice high-level overview for you guys. Those of you who are preparing for your boards, those of you who are preparing for your clinical practice, this is going to be a really nice high-level overview where I've thrown in a lot of questions from our question bank. I've put in a case study for us at the very end, but basically we're going to have some fun and talk about pediatrics. I know it's getting close to the holidays, so everyone's feeling a little bit burnt out. So my goal for you today is to have fun and learn something new while having fun. So without further ado, I want to introduce you guys to this new Slido tool that we've been trying here at Archer just to help with engagement for our webinars. It's a really nice, fun tool because instead of my asking questions and having you put it in the chat box, you can engage with us on Slido, which is really fun. So for those of you who've used it before, you probably know that if you scan this QR code, it'll take you to that first poll that I'm going to launch here today. And that's just going to be, where are you joining us from? So you'll see that poll. For those of you who've never used Slido before, you can scan this QR code, or you could go to slido.com and put in that hashtag PEDS for NPs. It'll ask you if you're joining a Slido or if you want to sign up for it. You just want to join our Slido today. And so this is a really nice, engaging way to participate. I've done it myself on the user end on my phone while I've been watching the webinars. So it's fun to kind of toggle back and forth. And when you're on Slido, it should put my screen, the presentation screen on the top right for you, so you're not missing out on anything. But go ahead and participate today. I'd love to see where everyone's coming from. Usually we get a lot of people, both domestic and international, so it's really fun to see that. And I see some of you are playing around with the Slido tool, that PEDS for NP. So you're already in the Slido. You don't need to type in PEDS for NPs. You did great. You just have to put in where you're joining from. And the other thing I really like about Slido is that it's anonymous. So you don't have to feel self-conscious about answering some of the questions, and students seem to appreciate that. So you can go ahead and give it a try without feeling self-conscious. If you want to get us directly, you can go ahead and send a message to us in the chat or the Q&A. Our lovely Sam is on the chat support today, so she'll be fielding those questions, and I'll also try to take a look at the chat while we're going through, just to make sure we're keeping it engaging. But I see that a lot of you are having fun with the Slido tool, which is great. I see some people from Florida, from Richmond, Virginia, San Francisco, the Philippines. So we do get some people internationally as well. Welcome. Texas. Yes, I'm in Texas currently too, so I love to see Texas pop up there. New Jersey, South Carolina, Mississippi. Awesome, you guys. So kind of from all over, which is really nice and fun to see. So now I'm going to launch our next poll, go into the next one, and I'm going to see who is in our audience today. And so I want you to put in a little bit about yourself. Are you an RN and you're thinking about pursuing your NP? Are you an NP student? Are you finishing up your schoolwork? So I know some schools, some programs do graduate in December. So have you graduated and you're getting ready for your boards? Tell me a little bit about you. So I see an NP student graduating in May. That's awesome. FNP student last semester. Yay! It's exciting, especially giving yourself that gift going into the holidays of like wrapping up school. That's fun. And seeing the finish line in May. That's really great. So an RN MSN taking ANCC soon. That's great. NP student. Already we have some FNPs, some FNPs who have passed the board and you want to do another certification. That's really smart. That's awesome. I think about that. I'm like, oh, maybe I should have gotten dual certified. I think Sam is dual certified, which is really nice, because then it's kind of, relieves that which one do you take, which one does your employer want kind of pathway question, right? And then LPN getting ready for your boards exam, RN taking NCLEX. Awesome. So a lot of different people from in different parts of your nursing career. So that's really great to see. And then one thing I just kind of wanted to make sure you guys knew that today we're going to have some fun. So how are we feeling about the holidays? I put this little face spectrum on there. I'm having fun with Slido with these emojis. If I were to put a face on there, I'd probably put this smiling face on there now that I'm on this webinar with you guys today. But I'm not going to lie, yesterday I think I was probably more on this end of the spectrum trying to get all the holiday shopping and the teacher gifts and all of that squared away on top of work and family obligations. So it is a stressful time of year. I want to bring a little cheer to you guys today in this webinar, but oh, good. Generally, we're all in good spirits. I love to see that. That's great. All right, and one more fun poll that I got inspired by one of our colleagues who used Slido earlier this week, and I was on that. She did something fun. I thought, that's really nice. So I'm going to do something fun too. So which would you rather have right now? A cup of coffee, a cup of hot cocoa, or something a little stronger? What do you guys think? Go ahead and put your responses in there for me. Oh, so a lot of cup of coffee. Yep, it is Wednesday morning. We're on this webinar. We're trying to make it through the week and really get everything squared away before the holidays so you can enjoy the holidays. A cup of cocoa that might put you to sleep. No one's marking something a little stronger. Good. I'm getting a sense of where you guys are at mentally for this webinar. So that's really great. All right, well, we had our fun. I'm going to leave that poll up, but continue on to our webinar. And you guys have now gotten a hang of using Slido, a lot of great participation. So now as we go through the webinar, you'll know how to go on there and go ahead and answer those questions. Awesome, awesome. So what are we going to talk about today? We're really focusing on how it looks on the primary care perspective, on the primary care end when you are seeing these pediatric patients. So I'm going to go through a lot of milestones, screenings, puberty, that kind of stuff. What I always like to start off with is milestones because our pediatric milestones are really our cornerstone of our pediatric care that we're providing to our community, right? These are those skills or those abilities that our children hit at different stages of their growth. And one person put this really beautifully, and I always think about this. Milestones are like your checkpoints. So say you're driving from point A to point B, you're driving from California to the East Coast, you're driving across country. Milestones are your checkpoints. So along the way, you're going to kind of plot where you're going, right? You're going to plot where you're going to stay overnight after a day of driving. You're going to plot how you're going to get to the next location. Milestones are that for our pediatric patients. So it's kind of benchmarks to get our kiddos to a healthy growth and developmental stage in adulthood. So with our milestones, every kid's going to hit those milestones at different points, right? You might hit some traffic along the way while you're driving cross country. You might take a detour and want to get a milkshake, get a DQ. If you see that off the highway, you're going to make a little detour. And that's okay. What we want to see in our kiddos is that they're generally moving in the right direction at their pace. So you as the clinician need to know when to be concerned when you're seeing our pediatric patients not hitting milestones and when to not be concerned and reassure those parents and reassure them that they will get there, right? So that's what I want you to be thinking about as we're talking about milestones. There are four main categories that we're looking at with milestones. One is that social emotional milestone. The other one is language communication milestone. We also have movement and physical development milestone and also that cognitive milestone. And we're really doing this at every stage. So even starting at that 1 to 2 month old stage. I really like that CDC app. It's useful to also recommend to your patients and those parents so that they can be tracking their kids' milestones. So if they see anything, they're going to be our first line, right? They're going to come into the clinic and say, hey, this is what it flagged. Let's talk about it and initiate that conversation. So the CDC has a nice app, and you'll probably see in your clinic, depending on your clinical setting, what you're going to use in clinic to help track and have these conversations about milestones. But as you're studying for the boards, I want you to be thinking about that child in your mind and visualizing that child to see if this is something that's appropriate for this child in this age group. So that's a nice little clinical pearl of how to study if if you don't necessarily have all that peds experience where it's becoming more intuitive for you. So at 1 to 2 months, we're really seeing that social smile, right? So we're already seeing that social emotional milestone. They're starting to observe others. So that's their communication, that's their language, also a cognitive milestone. They're able to hold their head up during tummy time. So that's another point that we want to stress to parents. You definitely want to get those kiddos on the ground and practicing tummy time early. Obviously, they won't be able to do it for a long time. Some are going to get really fussy. But why is that important? We really want those kiddos to be strengthening and developing the back of the neck to help lower their risks of SIDS, right? So getting them on tummy time as early as possible, that 1 to 2 months, it can seem really scary, especially to first-time parents when the babies are so little, but you got to help coach them through that, right? 2 to 4 months, they really should start having better head control. So you can see that in clinic when you're lifting their hands too, you're going to check that head control. They're going to start babbling. So again, they're hearing sounds, they're communicating. And so why is this important? Because we want to make sure that if they're not babbling, if they're really not making sound, did we miss something in that newborn screening? Can this patient hear, right? So all these milestones are really going to be our benchmarks to make sure that we are supporting that child's development. And so anytime they're not hitting a milestone, we want to think about it, is this generally across the board? This child just is a little bit more delayed and a little bit slower, because remember, these are averages. Some kids are going to be ahead, some kids are going to be behind, some kids are going to be right on target. So is this something that's across the board, or is it just one category this child is not consistently hitting that category, that milestone? That should be your red flag right there. And so anytime you see repetition like this, it's really for us to intervene early. That's the purpose. So by 6 months, they're really rolling from front to back. Some are really sitting up really well. I really love that 6 month phase because you can have them sit up with a nice pillow or something soft behind them with toys all around them, and they're just happy and smiling and happily playing. That's one of my favorite phases of life. But at this point, they're really recognizing familiar faces, and then starting solids is going to be another big conversation to have with your parents, because this will vary depending on the child and the current literature, right? When my firstborn was born, they advised us, and the current literature was saying hold off on solids till she's 6 months to help avoid those food allergies. And now they're saying let's get solids started early, around 4 months, to help avoid those food allergies. So you really have to be staying current when you get into practice to see how the recommendations are changing and how the research is supporting the newer recommendations, and go based off of that. But it's really going to be dependent on the child. So some kiddos, we really want to start a little bit earlier if we're seeing that weight drop with those screening tools that we have that we'll talk about in a bit. Okay, so now we're getting to more of the 9-month-old. And so the AAP says this 9-month check is really going to be the beginning of that designated screening interval where we really want to have a more in-depth assessment of whether they're hitting these milestones. So before that, we're going to make some observations. You're going to get into a rhythm and do it systematically so that you're kind of looking for the same thing in every visit. By 9 months, we're going to have more really formal tools and formal ways, more in-depth ways of assessing the child. So that 9-month, 18-month, and between 24 to 30 months, those are going to be the key 3 formal in-depth milestone check marks before the child turns 3 to make sure that we can intervene if we're noticing those red flags. But by 9 months, really kiddos are starting to crawl. Maybe they're saying mama or dada. That might be closer to 1 year of age. They might be waving. They have object permanence and that pincer grasp. So helping them practice that is going to be really helpful as well. And by 18 months, they're really very active, up, moving around, running. Even their word development, we really should see 50 words or more. We really want them to be developing that language milestone as well. And that starts in early days of encouraging parents to really read with those kiddos early on. And then the scribbling, we want to avoid crayons, but give them the opportunity to scribble. So there are a lot of different types of tools out there. I know I have these like little eggs that are crayons or little pebbles or different kind of objects where it's easier for the kiddos to grasp and you're just giving them a piece of paper or coloring paper and encouraging them to scribble. So you really want to talk to parents about that and encourage these activities at home and also ask what are they doing during the day? Are they doing these things at school? So having those conversations so that they're meeting these milestones. And then by 2 to 3 years, their language development, those milestones really kind of blow up and explode. 200 words. This is where we really notice those social interactions. And that's where those conversations are going to be really important about what is this child doing during the day and how much social interaction are they getting? And are they socially interacting appropriately, right? So this is where oftentimes we catch those early signs of autism. So we want to have those questions and also support our kiddos, making sure that we're reading to them about feelings, they know how to express feelings, because this is really where those tantrums start to come in because they just don't have the words for those big feelings yet. And then as we move on to the milestones, we have that preschool age. This is also a really fun age. This is where they really start to really explore those social relationships. So you see a lot of social emotional growth in this age. They're also developing their cognitive abilities. And we see a lot of major improvement in those fine motor skills. So they're starting to learn to really write their letters. And by school age, we're starting to really focus on those academic milestones. So again, to reiterate some red flags, if we see any regression in those milestones. So if a child has previously met a milestone and now they're regressing, that should be a big red flag. And then in these early stages, we really want to be looking at the social emotional development and how they're doing with those social interactions and watching those milestones as we go along. Again, I'm not so worried if they're across the board behind. What I worry about if there's a category where they're behind and they're meeting all the other milestones in the other categories and it's a consistent pattern, then that's something that I'd want to explore and do a more in-depth investigation. All right, so let's practice with our next poll, and I'm going to launch that for those of you who like to jump ahead, but I'm going to read it for us today. And so that Slido poll is up if you still have it on your phone or your computer. And so let's read it together. The nurse practitioner knows that a motor development milestone for a 4-year-old child includes which? Is it A, riding a tricycle, B, skipping and hopping proficiently on one foot, C, performing broad jumps, or D, walking on tiptoes? So I love our question bank because it really gives you a chance to practice what you've been reading to help solidify some of that, right? Especially if you don't have a lot of that PEDS experience going into it. And so this kind of gives you practice of like, okay, let me visualize this child. We're talking about a 4-year-old and we're looking at the motor development, right? So what are they asking here? What do we expect them to hit in terms of motor development, that milestone by 4 years old? What are we thinking, you guys? And I see some of you are answering. That's awesome. Yeah, it's kind of hard, right? Is it riding a tricycle? Is it 4-year-old riding a tricycle? Is that 3 years old? Should they be skipping and hopping? Should they be jumping, walking on tiptoes? What is it? Oh, it's so tough. Awesome. A lot of engagement today, you guys. This is great. This is really beneficial to you. Yeah, so the majority of you got it right. So skipping and hopping, proficient on one foot. So if you actually practice these milestones, it's kind of hard to do, right? That skipping and hopping on one foot is a milestone that they'll reach by 4. The riding a tricycle, performing those jumps, so those are 2-footed jumps, those broad jumps, walking on tiptoes, those are all things that they do on 2 feet, right? So that could be a way to eliminate the other responses as well. But those are really milestones that they're going to hit by age 3. That tricycle one's really tough because you're like, can a 3-year-old really be on a tricycle? But yes, absolutely. Even 2-year-olds I've seen on those cruise bikes now where they don't even have 3 wheels, they just have the 2 wheels. Those 2-year-olds are cruising. So absolutely, anytime you're on 2 feet, really that's by age 3. And then that 1 foot skill comes a little later by age 4. Awesome, awesome job, you guys. Let's move on to our next question. So now we're going to talk about screening. So what is the difference between milestones and screenings? Remember, milestones are those specific developmental skills or abilities the child develops. Screenings are just our formal tools to help measure those milestones to make sure that child is reaching that milestone, and we can intervene if they're not reaching the milestone. So the way I like to think about it is milestones are our benchmarks, and the screening tools are ways to measure those benchmarks and make sure we're hitting those benchmarks. So screening starts at that newborn phase in the hospital. Every state's going to be different, but globally, these are the three that we do tend to perform on in every state. I do encourage you for your clinical practice to really find out what they're doing locally in your state when you're practicing, just so you know in the back of your mind that, okay, when they're coming to see me for their well visit, I can get that paperwork and I see that they've passed all these things. Or if you're starting to see some gaps in those milestones, you can go back and be like, hey, what happened here? Did we miss this screening, right? So every newborn's getting that hearing screening. We're also doing bilirubin check, and we're also checking for any congenital heart disease. Those are the big three that we do for our newborns. And then as they come to see us for those well visits, we're doing screenings at every interval, 2, 4, 6 months, 12 months, and so forth. And so really at those intervals, in addition to those milestones, we're starting to measure length, weight, and head circumference. We tend to, depending on your clinical practice, most clinicians tend to transition away from head circumference around age 2 and start incorporating BMI. But for the most part, this is what it looks like before that 2 years. And then around 12 months, we check hemoglobin, hematocrit, and lead screening. So who can tell me, and you guys can put this in the little chat, but why are we checking for lead screening and hemoglobin, hematocrit at at that 12-month mark? Do you guys know? I'm going to get that chat open. Yeah, and I see Sam's talking about those neurologic screenings. Yeah, Texas, like I said, every state does it differently. Both Sam and I are in Texas, so we know the Texas law really well right now, and every state does it differently. So it's good to know what your state does. So we're checking that hemoglobin hematocrit because we're really looking for signs of anemia, and then we're looking for lead poisoning, right? Why are we doing a lead screening? Are we screening everyone for lead screenings? Not necessarily. Again, that's going to be state specific. That's also going to be clinical practice specific. So here in Texas, it's not required to check. However, our pediatrician, depending on the office location, so in our Dallas office, they screen everyone for lead because those houses are older. And then in our Plano office and our Frisco office, it's further north. Those houses are new. So they leave it up to the clinician to have that conversation with the patient. And so I always have my kiddos screened because lead poisoning is really hard to detect, right? It's really asymptomatic until those levels become really high. And then at that point, the damage is already done to the nervous system. And that can really cause some delays in growth and development and cognitive and behavioral problems. And so I know that my kids go to school in Dallas and they also go to friends' houses in Dallas, right? So for me, peace of mind, I have my kids screened, but really it's going to be a conversation that you need to initiate as a clinician. What are these kiddos doing during the day? What is the level of exposure? And how often are we screening and testing? But we're going to start that around the 12-month mark. Awesome job. Okay, so going into our next poll, I know I kind of digressed, but I really like to drive that lead poisoning home because I'm from Massachusetts, and so it's definitely something that was stressed to me during my training, and I like to stress it to you as well. Because in Massachusetts, we definitely screen everyone. All right, my friends, let's read the question together. This one was kind of wordy, so I summed it up for you guys on Slido, but let's read it together. A 4-year-old child presents to the clinic to establish care. The mother brings in copies of all immunization records and the last 2 office visit notes. The child was born without complication at 39 weeks, a full term, and had no chronic health issues. The child's otherwise doing well. The records report typical milestones in development and occasional viral or ear infections, not uncommon in this age group. So typically, this is a young, healthy child coming to you to establish care. What screening is required for this well visit? So let's go back to that slide, and I want you guys to take a minute and think about it. But what screenings are we thinking about in a healthy 4-year-old? Are we going to check their vision, lipid testing, PKU, TB? What do we think? Being a lot of participation. This is great. I can tell you guys are liking the Slido tool. That's fun. And I think across the board, wow. Wow, 100%. You guys all got it right. Absolutely. So vision is something that we're going to start in this 4-year-old. Remember, they're in that preschool age. So we definitely absolutely want to make sure that they can see so they can learn, right? They're about to really develop a lot cognitively. And so we want to make sure that we're doing a vision and hearing screening. Most kiddos who go to preschool, it's required around ages 4 to 5, and they're able to participate and cooperate with the screening in the clinic. And typically, because they don't all know their letters yet, some kiddos are ahead, some kiddos are right where they need to be. And so we use little shapes and they can tell us which shapes they see, right? But absolutely, vision is going to be what we're going to do at this visit. So let's talk about the ones that aren't the right answer. And I'll go briefly since you guys all got it right. We wouldn't be doing a lipid test because they're not really telling us anything that would be concerning in that realm, right? This is more something that we would be thinking about in adolescence, especially with family history and body habitus. So lipid testing is not appropriate with this 4-year-old. PKU testing, this is also part of that newborn screening. So again, not appropriate with this 4-year-old. And if it was abnormal, we would have seen some earlier signs by now, but not anything in this example or this test question that's leading us to think that that is the case. And then TB testing, again, not something that we do routinely. It's really if that patient, if that child has been exposed or we're worried about exposure, if we're worried they're high risk, then we would consider doing a TB screen. Awesome job, you guys. Very good. All right, moving on to the next one. So why do we do these screenings? Again, to catch things early so we can support that growth and development. Failure to thrive is one of the things that in primary care, we need to be well versed in how to identify it and begin to identify the cause so that we can address the cause and get that child back on the normal growth curve, right? So how do we define failure to thrive? It's anything below that 5th percentile for weight. That's a big one. And you can also classify it with a decrease of more than 2 major percentiles on that growth chart. So if the child was doing well and then all of a sudden you see a drop in that weight and height, then that can qualify for failure to thrive. What's happening? Why are they dropping off that growth curve? Now, I will say the head circumference is usually the one that's preserved last, so we will see those changes mostly in that height and weight first. And then another way you can define it or classify it, less than 80% of average weight based on the height and weight ratio. There are a lot of different causes of failure to thrive. We break them down into 3 main categories. It could be due to inadequate caloric intake, malabsorption, or increased caloric demand. And there are a lot of subcategories that fall into all of that, but you really need to be thinking about, is this patient getting enough food? Maybe it's a young 4-month-old who's starting to drop a little bit and it's time to start solids, right? Is it due to a GI or chronic GI issue? Is there malabsorption happening? Is this neglect? Is this a financial issue? Do I need to get this family more support, right? Can they not afford enough nutrition? Is mom able to breastfeed? Is mom able to get the formula that she needs? Are we meeting this child's caloric demand? And is there increased caloric demand? So is there something going on? Is there a tumor or something that's a big red flag? Why are we dropping off this growth curve? So really thinking about the causes, addressing those causes, and getting our kiddos back on their growth curve are going to be our main priority as primary care clinicians. So other big warning signs that these milestones and screening tools help us identify. We also, like I said, we want to be looking for early signs of autism so we can give that child the support that they need. What are some warning signs for autism? That regression of previously met milestones is a big one, right? And then again, we want to see how are they doing with their social interactions? What kind of social interaction are they getting during the day? Are they nonverbal? That's a big red flag. Do they lack eye contact? Are they making eye contact with you in the visit? Some kiddos get really shy, so it's okay if they're kind of, burrowing into mom and dad, but you want to ask, like, how do they do with their peers? How are they doing when they're at school or when they're at the playground? Are they interacting, right? And then you also want to see that they're really responding with expression, right? Both facial and to verbal expression. That hypersensitivity is a little bit tricky. It's a gray area, but sometimes we will see that extreme interest in specific topics. That's going to be more kids who are really distracted. You can't get them to focus on what you need them to focus on because they're so distracted in what they are thinking about and that extreme interest that you can't really get them to engage with you. So it's really more about that engagement. What do we do if we suspect that we could have a possible behavioral issue, or maybe we're thinking about autism spectrum? We definitely want to get them over to psychiatry, and they're going to do a lot more testing, use the DSM-5 criteria, and then they will make their recommendations about what is appropriate for that child. All right, you guys, so before we jump into our next section talking about vaccines and puberty, I want to take a little brain pause because I know that was a lot, like a lot of high level information. And so that's what I wanted to stress today is that we were going high level. If you want to get really deep down into the weeds, this is a really good time to utilize those on-demand videos. So we have over 16 hours of content and they're broken down to bite size, and you can really go in depth into that. A lot of the questions, or all the questions I pulled for you today, are from our question bank. And the question bank is a really nice tool to use to help you identify those areas that you need to go back and review a little bit more in depth. We also give really rich rationale with the question bank. So a lot of it we discussed today, but when you're sitting down and you're studying, you can read through the rationale and you learn a lot from the rationale. We do have a free trial on it. It gives you a readiness predictor. So if you score high or very high, you're ready for your boards exams. It's a really nice thing to have to reassure you before you go into your boards. And generally, if students take 1,000 questions, they're ready for their boards. So we have over 1,600, so you can really pick and choose and use, you can filter it through the unused button. So use the ones you haven't practiced on before once you're getting really more closer to your test date and feeling more ready. But it's a really nice tool to have. And then you can, there are different bundles where you could just pick and choose a la carte or bundle them together. But I really recommend the SurePass Pro because that pulls in the mentoring and also pulls in that live 3-day review that we have. And we're doing a lot of those in 2025, starting with that second week in January. And so that's a nice way to get that high level overview, get the mentoring if you need help with coming up with a study plan, or if there's a topic that you just need more coaching on, or if you just need more help in general about getting through school, getting through your clinicals, and you need that support. It's a really nice tool to have. And we are a nice community here at Archer where we don't believe in nurses eating their young. We're trying to change that culture. If you guys know us, if you know Archer, if you've been following us, you know that we're very nurturing and we want to make sure that we're supporting the whole nurse through the whole journey to keep you in nursing and have you thrive in your nursing career. So that is our #1 goal. So take a little brain pause, think about it. If you haven't already joined our social, definitely do that because all this free content is available through our Facebook group, and there's a little QR code for it there. And Sam does an awesome job of uploading all of these free webinars onto that social group so that you can go back and watch all the topics that we've done in the past and all the topics we're going to do in the future. All right, so let's jump to our next section, vaccines. So vaccines are a tricky one because for the purposes of your boards, you do need to practice and memorize this vaccine schedule. But in clinical practice, you're obviously always going to be referencing it for that patient visit. So it's a little tricky in that sense, but the way I recommend practicing vaccines is take a moment and look for patterns. You can also come up with mnemonics. Like here, you'll see that we highlighted that D, the R in rotavirus, IPV, P. So the mnemonic here is drip. So you can come up with little mnemonics to try to remind yourself of like, okay, what are they getting at that 2, 4, and 6-month visit? Drip, right? They're getting their D, TAP, rotavirus, IPV, and that pneumonia vaccine. And then you can look at Hib, and then you can look at the Hep B. So hepatitis B starts at birth, right? So regardless of that child and the status that they're born, they're going to be given that hepatitis B vaccine, and they're going to get 3 doses before 6 months. So looking for patterns like that when you're studying The vaccine schedules are going to be really helpful. And then just drilling practice questions, right? That's going to help you have this in front of you, drill the practice questions, and you'll start to recognize patterns. So you'll start to see that we're really not giving the MMR and varicella until 12 months. They get their second booster at 4 to 6 months. They might give you a clinical scenario like this. So I'm going to pull that up for you guys, and I'll launch this next poll. We'll go to poll number 7. Okay, so let's read it together. The nurse practitioner prescribes administration of which vaccine for the term newborn within 24 hours of delivery? So what do you guys think it is? Is it A, B, C, or D? Yeah, right off the bat, you guys are doing great. You're listening. You got this down. I can tell you're feeling confident. Yeah, so hepatitis B again happens at that newborn phase, right? 6 doses within 6 months. And this is a full term, the term newborn at 24 months, right after, 24 hours right after delivery. Absolutely. We're going to give this newborn the Hep B vaccine. Awesome job. So that's the way it might come up. It might be straightforward like that. They might give you something more like an exanthem that pops up and that child has missed their vaccine. So drilling these practice questions is going to be really helpful for you. So let's practice another one together. So the nurse practitioner knows that infants can start receiving the diphtheria, tetanus, and pertussis, that's the DTaP vaccine, at what age? And remember that pneumonic drip. So when are we starting that DTaP? Yes, you guys are awesome. 100% across the board. We're going to start it at 2 months. Remember, they're going to get it at 2, 4, and 6 months with that drip pneumonic. You know that. But practicing with the question bank is going to be really, really beneficial to you. Okay, let's jump into puberty. So this one, I think you probably get a lot of exam questions from puberty, and it's probably the most challenging because unless you've seen these patients, unless you've gone through the Tanner stages with patient after patient, it's not really something that's second nature in your brain, right? But luckily we do have the Tanner staging, so we have something to go off of. And so in our females, we're looking at their stage of puberty with their breast development and also the pubic hair in their private area. So we're going to stage them from stage 1 to 5, 1 being that prepubescent stage and stage 5 where it marks that sexual maturity. And so you might get questions that want you to know, is this something that you should be worried about, or is this going to be something that you should reassure the family on? And I'll pop in some of those practice questions in a minute. And then with our male Tanner staging, we're mostly looking at the testicular size, the scrotal development, and the penile development along with the pubic hair. Again, we have that stage 1, that prepubescent, to stage 5, which is going to be that full maturity, sexual maturity. So here is the next poll. We're going to go to poll 9. But what do you guys think? For our male patients, which comes first? So what are we going to see first in terms of development? Are we going to see testicular enlargement or penile enlargement? And that's straight from our Q bank. I just summarized it for us here, but things like that, they might want you to know or reassure the patient that if they're seeing certain developing first, that that's part of normal development. That's part of their normal Tanner stage. Yeah, so absolutely. So oftentimes it's perfectly normal to see that testicular enlargement, and then you'll see the penile enlargement. That's absolutely the case. Very good. Okay, so now going to our next question, poll. Oops, made that too big. Poll number 10. And so this one gets a little wordy, so we'll read it on the slide, but it's activated in Slido. So if you're ready to answer, you can answer, but let's go ahead and read it in our Canvas slide. So a 13-year-old male presents to the clinic for an annual exam. The patient reports his breasts are becoming larger. Upon physical exam, the nurse practitioner notes bilateral breast enlargement with no masses. So that's really important. So every time we see that extra tissue, we're going to feel for those masses, right? Besides the bilateral breast enlargement, the nurse practitioner notes that all systems are within normal limits. Which of the following is the most appropriate intervention? So otherwise, child is doing well, meeting milestones. What do we think? Do we need to intervene? Do we need to start this patient on testosterone therapy? Do we need to prescribe an estrogen blocker? Do we need to refer them over to a pediatric endocrinologist to do more evaluation? Or do we reassure this patient and their family that this is a normal finding when this child is going through this stage of development? What do we think, you guys? Yeah, I see that. I see the wheels turning. It's like, oh, do I send over to the pediatric endocrinologist? I don't know. It is gynecomastia. Is this normal? Is it not? Yeah. So this child is 13 years old. And so this gynecomastia is a perfectly normal part of their sexual development, right? And typically we'll see this peak between ages of 10 to 12 or right around that 13-year-old mark. This patient, I keep wanting to say student, this patient is probably in that Tanner stage 3. And so this is something that's part of their normal development due to the hormonal changes and something that does typically go away. And so reassuring this patient is going to be really helpful in talking to them about the fact that it does typically go away within 6 months to 2 years as they're going through those Tanner stages, as they're continuing to grow and develop. And so the trick here is that oftentimes patients will come in with this concern. And this is a very common complaint from our young male population because they're starting to be really aware of their body and their sexuality, and they're going through all these different awkward changes, and they start to develop a little bit of a breast budding. And so they start to get really worried and really start to obsess about it. And so from our point of view as clinicians, really trying to reassure patients that this is part of normal growth and development is going to be important. If we were to start that patient on testosterone therapy, that's actually going to exacerbate the issue and worsen the gynecomastia. Same with if we were to start an estrogen blocker, that's going to hurt their growth and development. And then referring to a pediatric endocrinologist is really just a waste of resources. It's not going to be useful. However, I will say, being on the pediatric endocrinology side, we do have patients coming in where the primary care clinician has tried over and over again to reassure this patient, and they are just so worried that they do want all the hormonal markers checked. They want everything. They want a full evaluation. So that's when they come to pediatric endocrinology. The pediatric endocrinologist reassures them, but that patient is still really anxious about this. And in those scenarios, the literature does say that you can send them over for a surgical eval, but it really breaks my heart because I really don't want to see that happening so early on in our young male population, right? So like we talk about body love and self-love in our females, I also want to encourage that in our young males as well, right? All right, I digress. Let's move on. So we definitely want to make sure we're looking for those signs of abnormality. So precocious puberty is definitely one of those red flags. So if we're starting to see those early secondary sex characteristics, females, remember before the age of 8, 8 is perfectly normal. Even if it's a young 8, that's normal. But if we're seeing it earlier than 8, then that's not normal. Same with males, earlier than 9. Again, 9 is normal. But if we're seeing those secondary sex characteristics, so we start to see some hair in the pubic area, maybe some body odor, some breast budding, we want to evaluate that and figure out the underlying cause. Most of the time, it's really because mom and dad are on hormone replacement therapy and it's a gel that they're rubbing somewhere that's getting on to the kiddo. But we definitely want to make sure that we're sending them over to pediatric endocrinology so they can screen them appropriately if necessary by getting a bone age, checking those hormonal markers, and testing for any genetic conditions that could be causing it, right? So what do we need to know as primary care clinicians is how to spot it. So I'm going to launch our next poll, but our job is to really make sure if we are seeing those early signs, what is appropriate, what is not appropriate, what is an early sign, right? What is precocious puberty so we can get them over to the specialist. So which of the following child exhibits precocious puberty? Is it A, B, C, or D? What do you guys think? Yeah, it's a tricky one, right? And that's why these practice questions are so nice to have because you practice, practice, it gives you the rationale, you go back, you look at that Tanner stage, you study it again, and then it solidifies. Yeah, awesome participation, you guys. So C is absolutely the right answer. So that girl is showing signs of precocious puberty because remember, 8 years old is normal, anything less than 8, and she's showing some signs by having some pubic hair developing before the age of 8. Awesome job. On the other end of the spectrum, we also want to look out for signs of delayed puberty. So late secondary sex characteristics. Again, females 13 is normal. Anything after 13, we worry about. Males 14 is normal. Anything after 14, we worry about. A lot of these, the causes are going to be genetic conditions. So knowing the different genetic conditions that it could possibly be and some of those clinical features that we might see on exam is going to be something that they'll probably expect you to know as a primary care NP sitting for your boards. But anytime we're suspecting delayed puberty, again, we're going to send them over to the specialist and they're going to do their full workup and see what's going on. Let's practice it. How may that come up on a boards question for us sitting for our primary care NP boards? So which of the following or what chromosomal abnormalities are known to cause a delay in puberty? Select all that apply. For those of you who are sitting for ANCC boards, they will have select all that apply questions and they'll tell you how many answers are right. So that's really nice. That's been a change in recent years. And in this scenario, 2 of the answers are right, 2 out of the 4. So I'll give you guys some time to think about it and let me know what you think. But what could be a potential cause of delayed puberty? And remember, this is anonymous, so I want you guys to feel comfortable taking a guess. This might be an area you need to go back and read a little bit more about. Again, our on-demand videos, we do go in depth with this topic as well, so you can see all the different chromosomal abnormalities and learn about them, practice these questions in our Q bank. Yeah, so A and C are correct. So Turner's and Klinefelter syndrome are 2 main causes of delay in puberty. Awesome job, you guys. All right, so before we move on to our last case study, I want to remind you guys about these wonderful tools that we have. Again, that SurePass Pro pulls them all in. So you get our Q Bank, our on-demand video, the live 3-day reviews that are starting in January again. I know with the holidays, everyone's taking a little rest. And it gives you a mentoring session. So you can test it out, see if it's for you, see if it's helping. We get a lot of students using the mentoring feature through their NP program as well as getting ready to sit for their boards. So it's a really nice feature to have somebody in your corner. I would not have made it as long as I did as an NP if I didn't have other NPs in my corner. So that is a really important thing to have. Make sure you do have that mentoring, whether it's through the Archer community or a different community. And absolutely join our community, but if anything, you don't do anything else, join the community, get the free content, and then try that free trial of the Q Bank. That's going to be really helpful. All right, so let's jump to our case study. So here we're meeting Sarah. Doesn't she look super cute? She's a 12-year-old female, doing great, lives with both parents, comes into your office, generally smiling. She's not in any acute distress. She's having a great time. Her height and weight, she's meeting all those markers. She's also up to date with her vaccines. She's coming in with a chief complaint of mild back pain. And so she's in her medical history, you're noticing on those growth charts that she's recently hit a growth spurt, right, in the past 6 months. And she's also telling you that she started her menstrual cycle about 2 months ago. Past medical history, no, nothing significant. She's otherwise young, healthy, no injuries, no hospitalizations, no surgeries. Family history, you do your due diligence and you ask those questions. Dad, he was diagnosed with mild scoliosis as a teen, but never needed treatment. And mom, otherwise unremarkable history, healthy, doing well. So for Sarah, what do you think? What are we thinking at the top of our mind for Sarah? And I'm going to launch a poll where you can just type, it's free type for you. But what do you think we should do next with Sarah? What are some things that are popping up in your mind with this complaint? Do you need some more information? Do you already have your list of differentials? What are we thinking for Sarah coming in with a chief complaint of mild back pain? Yeah, so check for scoliosis, check for scoliosis. So I'm seeing scoliosis. So you're starting to think about your list of differentials. This is great. Do you need some more information before you can jump to scoliosis as a diagnosis? What do you guys think? So I'm seeing some ask about, good. Ask about pain, good. You're going to ask, how bad is the pain? Where is it located? Our old cart, right? That's wonderful. I remember as a new NP, I hung on to old cart for dear life because I would get into the appointment and I'd get really nervous and flustered and forget everything. And so if you just slow it down and gather more information, more of a history, I love seeing that. Awesome job. So grab those questions. We're going to be asking more questions. Very good. Um, Very, very nice. So absolutely. So you do your due diligence and you old card it, right? So you're going to ask, when did it start? Where is it located? How long does it last? What aggravates it? What makes it better? What have you tried? And so the history reveals that actually, as you're having this conversation, she says, you know what? The school nurse recently did identify a possible spinal curve during a routine scoliosis screen, and we forgot to bring it in, or she never mentioned it to her parents. And this is the first time the parents are hearing it in the visit, right? And then Sarah reports that the pain started a few months ago. Remember, she had that growth spurt 6 months ago. So certainly growth spurts can progress that curvature. So it's an increased risk during those growth spurt phases. You'll see more progression of that curvature in that spine. So that's part of her history. And then it's located in that lower back bilaterally. It comes and goes. It's aggravated by prolonged sitting or standing. And then you do your due diligence and ask those neuro questions to make sure we're not missing any impingement in that spine, right? And so it's not coming from the spine. She doesn't have any weakness, numbness, no limitation in her daily activity, no incontinence, nothing like that. So what are we thinking? What's at the top of our list of differentials? You guys already said that, but let's go to that poll. But you guys are all on the right page. What's at the top of our list of differentials? Yes, so scoliosis is what we're thinking. Yeah. So now with that, before we even touch the patient, we already have what we're thinking top of mind. Now we're going to do our physical exam. And jumped two. So what do we find on the physical exam? We're checking her posture and her gait, and we have her stand facing the wall. We see her back, hands down by her side, feet together, and we are noticing that unevenness in that shoulder height, right? The right is higher than the left. We're also seeing that right scapula protrusion or prominence on that side, which makes sense. And then we're having her do the Adams test. Do you guys remember what the Adams test is? We're going to have her facing away from us, reach down and have her hands dangling and try to touch her toes. And we're noticing that that right rib on that thoracic region is more prominent. So it's all looking pretty consistent. We're also going to do our neuro exam, again, making sure there are no neurological findings. All that's normal, normal reflexes, normal strength, normal sensation, her balance, coordination, all that is fine. And then while you have her on the table, you're also going to check that leg length and notice no discrepancies. So all of it is looking normal. So does the exam confirm our diagnosis? And so I'll launch that poll. Is that a yes or no? Is the exam confirming our diagnosis or does it support our diagnosis? So does the exam confirm it? This is a little bit of a trick question the way I asked it. So does the exam confirm our diagnosis? Can we say, yes, you have scoliosis? Here, I'm going to send you over to pediatric ortho, or do we need to do a little bit more work? Yeah, so the exam supports our top differential diagnosis, but it's not confirming our diagnosis, right? What do we need to do next to confirm our diagnosis? I'm going to go to that next poll. What do we need to do next to actually confirm that this is scoliosis? You guys can free text here. What do you guys think? X-ray. Yeah, absolutely. Absolutely. So we need to get an X-ray. So we need to confirm that diagnosis with an X-ray. You're going to get a standing PA and lateral spinal X-rays. And most likely it's going to show some curvature in that spine. And most likely it's going to confirm our diagnosis of adolescent idiopathic scoliosis. Very good. So these are those exams, those assessments we talked about in today's lecture. Remember, you're going to look for that shoulder height. You're going to have them standing facing the wall. You can evaluate the shoulder height and look at the scapula as well while they're looking away from the wall, and then have them bend down and try to touch their toes. And that's our Adams test. So this is a great, these are all great assessment tools that you need to know about. And we're going to get that X-ray to confirm that diagnosis and then send them over to our pediatric orthopedic specialist once we know how much that spine is actually curved. Now, remember, when you're referring patients, you want to give them a lot of anticipatory guidance. The referral process from a patient end is kind of terrible these days. And so you want to make sure that you're supporting them through that referral process and talking to them about what's going to happen, right? You're going to tell them that the X-ray is going to come back, you're going to interpret it, and then you're going to determine what's happening next. Likely, they'll need to see pediatric ortho. And pediatric ortho will either monitor them and observe them for a little while and do frequent X-rays and checks at frequent intervals, or they might start bracing depending on the level of curvature in the spine. So giving them some of that anticipatory guidance is going to be really important so that they're not kind of just like floating out into the healthcare space, right? You also want to talk to them about their chief complaint. They came in talking about mid-back pain. So helping that child, making sure they're staying active is going to be really important. So you may want to initiate that physical therapy referral at the same time, right? And help them with their core strength, their postural exercises, also with pain management, and then also discuss the importance of making sure they're maintaining physical activity, but what kind of activity to avoid, like prolonged sitting or prolonged standing, which is what seems to be exacerbating it as well. And then you can talk to them about NSAIDs and how to use NSAIDs also for pain management, depending on their level of discomfort. But follow up with you is going to be really important because the referral process sometimes takes a long time, and you want to make sure that you're supporting these patients. And so making sure you're scheduling that follow-up so you can determine what's happened so far, where are we at in this process, and how's it going with pediatric ortho, how's it going with physical therapy, how are we doing with our overall activity level and pain management. This is going to be really important and just really good care to provide to your patients. All right, you guys, that was the end of our presentation with 3 minutes to spare. I'm going to open it up to a Q&A. I'm also going to launch our last poll today of how did you like Slido? And I just left it as stars. I wanted to do emojis, but I was like, I don't want to overdo it with emojis, even though that's how I text for those of you who text with me. But how did you guys like Slido? Did it help you engage in today's lecture? Did it help solidify some of these concepts and make it feel more like you were able to interact with us? It's something that we've been playing around with and something we're going to continue to incorporate into our webinar. So it's nice to get some feedback from you guys. And so overall, it looks like you guys seem to like Slido, which is great. I'm going to leave that poll open. You guys can continue to put your responses in there, but I want to make sure you had this last slide before anybody needs to jump off. But definitely, if anything, I want you guys to try that free trial of the QBank. You'll be really pleasantly surprised. There were a couple I grabbed from there, but there were so many to choose from, and I was tempted to throw them all in today's webinar, but I know we only have an hour together, and I want to respect your time and make sure that we keep it to that hour. So I limited myself with those QBank questions, but there's so many on there. We have over 1,600. And so if anything else, I want you guys to try that QBank, that free trial, and see how you like it, and join our community, our Facebook group, to get all this awesome free content for you. Our CEO is really all about making sure the content is affordable and available to nurses, which is a blessing considering all the high sticker prices that are out there, which is shocking to me, and because school already costs a lot, right? So to have to then pay all this money for mentoring and test prep, it's really a lot. So Archer does a really good job of making sure that it's something that's affordable and accessible to everyone, and it's a high quality resource. So if anything, if you don't do anything else, at least join our community, get that free content, try the free trial in the QBank, and then I think you're going to be really pleasantly surprised. If you're ready to take that dive with the 3-day live review and the mentoring on top of everything else, scan this QR code for the SurePass Pro, and we would love to support you in your nursing journey. And for those of you who have to hop off, happy holidays. Thank you so much for joining me today. I really have such a nice time lecturing to you guys, especially about my favorite topic, pediatrics. And I hope you guys get the opportunity to serve this wonderful patient population. Enjoy the rest of your day. And so Amber asks, are there any previous webinars on the site? Absolutely. Dating back to last spring, where we started putting them really on our Facebook page. So you can go and see all those webinars and all the different topics that we've presented on in the past. And we really try to make sure we cover all the different topics. So absolutely, Amber. Yeah, definitely utilize that. So join the Facebook group and get all that great, meaty free content. Yeah. Oh, that's right. Sam reminded me, for anybody who's still on, we're doing a lot of giveaways for the holidays. I'm sorry, Sam, I forgot all about that. But yes, we're doing all those awesome giveaways. So definitely follow us on our social, and get in on all the amazing things that Sam's going to be giving away in the next couple of weeks. Oh, bummer, I forgot to say that, but it looks like people are still on. So hopefully you guys heard that and joined our social. Sorry, Sam, I spaced on that today. Thank you, Sarah, for joining us today. All right. I'm not seeing any more questions. So thank you so much, you guys, and happy holidays. Enjoy the rest of your day.